They should have experience in wide variety of surgical procedures because we can offer the services to general orthopedic, neurosurgical procedure, brain surgeries, vascular surgeries, ENT surgeries, head and neck surgeries. So they're different, and sometimes even general surgeries and nephrological surgeries, they have application when the nervous tissue is at risk. Also do a random quality assurance for all the cases we do. So every case which has some type of incident or some type of changes, it may not be related to surgery, it may be technical or related to anesthesia or any other factors. We go and randomly evaluate those and give a feedback to the technologists. We also do another random testing. So we have that quality assurance department, and we have people, and every person in the company is trained to do quality assurance for other technologies. How we are. We want to have a difference. We don't want to be any other monitoring company. We want to separate ourselves with other neuromonitoring by higher standard, by providing the best education, by providing the best services, and by providing the best technologists. And the way we do is involve more and more people. So it's not depending on one person or two people, but it's part of a big group decision. So it's a benefit to teach, because there's something when most of the surgeons, they're trained to do, and their expertise, and they do very good job. But because of different patient pathology and their anatomy and diseases, sometimes data can change. It could be because of change in anesthesia or change in the temperature, or nothing. Sometimes it's nothing to do with the surgery, but that can affect the patient outcome. Patient may have a deficit. So identifying those things and discussing with other colleagues and other, so that's very important for us, and that makes us different than any other monitoring company. Instead of just sending one technologist to the operating room, and which is a typical, I have one technologist in the operating room, and there's a leading physician or online neurologist. Either they are in the hospital, they come and they can go from one operating room to the other operating room, or the other way is the remote physician, remote monitoring. They are connected and they are live throughout the surgical procedure. We offer an extra support. We have a senior technologist available throughout the surgical procedure if needed. We have a DPNM level neurophysiologist, which is also available. If there's a case, we can log on at the same time. And we also have IT department. They are available. So there's a technical issue. So there are multiple people. We get multiple support. So we have a team approach to give. So if there's a change or there's a technologist in the room, they need help, or they need to make a special decision or troubleshoot a problem, they have resources available throughout the surgical procedure every day to help them. For continuing education, we have online programs. We have created an online portal education platform. And we have created different type of material depending on surgery and different testing. And every employee, we are selecting the employee, like we have people in Dallas and Houston and Western Texas. So depending on their seniority and the demand in their region, we select people, and they assign to, like, a group of technologists assigned to a brain surgeries or brain mapping case. Another group is assigned how to monitor the thyroid case. Another group is assigned to know how to do a spinal cord tumor surgery, or spinal cord stimulator implant, or carotid endarterectomy. So they are assigned they go and they read all the material, online material, there are literature, so they have to review those papers, and there's a quiz. They have to take the quiz at the end in order to get the certificate. And then they come to the office, or we have online, they make a presentation. And so that's the first step, to go through the online material, because theoretical knowledge is the most important part before you go to the clinical site. So once you have that theoretical knowledge, then you go to the clinical site and then work with some other senior neurophysiologists for continuing education as learning and training in that type of surgery in the country. Right. But we make it because the presentation and education, educating other people is the way you learn. When you're presenting something, research and create the material. So best part of learning is to teach somebody else. A very good tool for learning, because when you are presenting to somebody, you have to go and prepare for that. And when you're preparing, you are willing to go and read and understand that. You cannot present unless you understand yourself. And so that's a very good point, tool to learn. So we make the presentations part of our continuing education because they are learning more. Like different cases every month for different technologists every week, and they go through QA process. We have a core group of technologists. They are responsible for make sure everyone is doing that, and every technologist is trained to do quality assurance on other people. So every person in the company, they are doing QA and on another case where they are not the primary technologist, and we try to do as many cases as possible. So the case is assigned to them. They go through the case and they go through the chat log, what was event log, how the technologists documented the cases, did they interact with the surgeon before the surgery, they enter that information, they talk to the patient, they enter the information, they talk to the reading physician, online physician, they enter the information, and they were checking the vital signs throughout the surgical procedure, how frequently they are learning, because sometimes they go and enter the information at the beginning of surgery, at the end of surgery, but that's not helpful. You want to have very frequent, every 15-20 minutes. So if there's a change, you can correlate the change to the change in the vital signs also. Then how the patient was set up, so they enter the information. The QA person who's doing the QA, they look at the data. If they were recording every channel correctly, they were using the stimulation parameter according to the guideline, they were not deviating. If there's a deviation or there's a change, there should be a good explanation for that, and that should be entered. And at the end, they get scoring. Everyone get a score on every QA. So there are 2 scores for every technologist on every QA. They get score on the technical side and their knowledge side. So how they operated the case and what was their knowledge base. And they're supposed to have more than 90% score, 95% score. Very couple of colleges in the country, they are offering education or training in intraoperative monitoring. The training is given by the different companies at different levels, and every monitoring company, every hospital, every program have different standard. So keeping the standard above, and there's a recommended guidelines. So, but the guidelines are the minimum guidelines. We have to go beyond the guidelines to give. We also try to encourage people to do the research, collaborate with the surgeon, with the staff, and if you have a new technique, a new modality or new test where we can give the patient more benefit, so do some studies, get the data, and publish that. First company, our goal is always keeping the patient on top priority. The service is provided for the best for protection of the patient. So the main purpose, so the tests are the same. They are being used in clinical setting for many years. But applying those tests in the OR make a difference, because when you are doing the same test, sensory test, motor or hearing test, you are just diagnosing a disease. As a patient has epilepsy or patient has myasthenia gravis or any type of disease. But we like to take that. We are taking those tests in the intraoperative monitoring field in the OR. When the patient walk into the OR or taking into the OR for any surgical procedure, we try to make sure they don't leave with any more deficit. If they have any deficit, they should not leave with any more deficit. If they don't have deficit, they should not have any deficit postoperatively. So that's our top priority. And whatever we do, the education, the quality assurance, the surgeon education, the IP education for the physicians, participation at the national level, conferences, the whole purpose is always going back to make sure the whole purpose is that the patient if the patient